response within the U.S. Department of Health and Human Services. So again, the content of the webinar is presented by the individual speakers only, doesn't reflect the official policy or position of any portion of the United States government or the Henry M. Jackson Foundation. Again, the content is not meant to be a substitute for medical professional advice, diagnosis, or treatment. So the information should be adapted to each specific patient based on the treating medical professional's independent judgment and consideration of the patient's needs. These speakers have no affiliation or financial interests or relationships to disclose. So I'm your moderator today for the panel. And again, we'll be monitoring the Q&A in the chat, and then we have a lot to get through. We have two speakers, Dr. Jason Zucker, who's Assistant Professor of Medicine at Columbia University of Physicians and Surgeons, and Dr. Kevin Ard, who's the Clinical Director of the Outpatient Division of Infectious Diseases at Massachusetts General Hospital, and is faculty in the Sylvie Rattel HIV STD Prevention Training Center. Learning objectives for today. We'd like to have everyone at the end of this understand updated information on Mpox virus, the epidemiology of Mpox and clinical manifestations, and then identify current approaches to Mpox treatment in line with recent data, and discuss prevention strategies for Mpox, including vaccination. So we will start off now with Dr. Kevin Ard. Welcome.
Thank you, Erica. It's great to be here. Hi, everyone. I'm Kevin Ard. I am the co-clinical director in the Division of Infectious Diseases at Mass General, and I'll be talking about Mpox epidemiology, clinical manifestations, and testing. We'll begin with a case. This is a 30-year-old cisgender man who presents with a 3-day history of bumps on the penis and on the groin. Today at the visit, he has 5 lesions. They're minimally painful, and he has no systemic symptoms. This is not a photo from him, but it is a representative image showing you these umbilicated papules, which appear to have a necrotic center and then some redness around them. He's on oral pre-exposure prophylaxis for HIV. He doesn't have any chronic medical problems. And he reports condomless sex with 2 cisgender men in the past month. He completed the Mpox vaccine series 2 years ago, and he's not traveled outside of his state in the US in the past month. So this case, I think, illustrates many features of the Mpox outbreak that we've been addressing in the US for the past few years. I want to show you some epidemiologic characteristics of people who've had this outbreak. And I want to highlight, because we now are seeing a different clade of Mpox, that the outbreak we've been dealing with since 2022 is the clade 2 version of the virus that causes Mpox. This virus also has a clade 1, and there has been an outbreak of clade 1 in Democratic Republic of Congo and other parts of Africa, with some cases sporadically around the world. We'll talk about that more in a few moments. But in terms of the clade 2 outbreak, again, which we've been addressing since 2022, this has predominantly affected cisgender men, as you can see here, with 95% of affected people being cisgender men. Most of those affected are in the age group of 21 to 55. And you can see that people who identify as Black or African American and non-Hispanic are disproportionately impacted by this infection in the US. People who identify as white and non-Hispanic are also about 1/3 of those affected, as are those who identify as Hispanic or Latino. Most of the affected cisgender men have been gay, bisexual, or other men who have sex with men, like the patient in our case. And in the US, about 38% of cases have occurred among people with HIV. Among those who have HIV that's well controlled on treatment, people often do well with this infection. They will recover spontaneously. But among people who have high viral loads and low CD4 counts or advanced AIDS, they may experience more severe manifestations. And we'll talk about that a bit more in a few moments. Most deaths due to Mpox in this country have been among people with HIV-associated immunocompromise. Now, as I mentioned, there is an ongoing clade 1 outbreak in Central Africa. And the country that's been most affected is the Democratic Republic of Congo. Since January 1st of 2024, they've had 33,000 suspected Mpox cases and more than 1,000 deaths. Historically, clade 1 has been considered more severe than clade 2. And historically, the mortality rate has been higher, although the mortality rate may be lower in recent contexts. And in particular, in one study that my colleague Jason Zucker will mention later, the mortality rate was overall low than what has been observed or reported in the past. Now, there have been cases of clade 1 outside of Africa. One was reported in Sweden in August of 2024, in Thailand the same month, in India, that should be September of 2024, in Germany a month later, in the United Kingdom this month. And then we had to submit these slides in advance. And of course, at that time, we didn't know that last Friday there would be a clade 1 case reported in the US in California. These cases have predominantly occurred among people who have traveled to areas where this larger outbreak is occurring. The individual affected in the US is reportedly recovering well with supportive care alone and has mild illness. I now want to spend a few moments talking about the clinical manifestations of Mpox. This table shows the way that the rash of Mpox may evolve over time. When I first saw this a few years ago, it really struck me as a glossary of dermatologic terms. These lesions can begin as macules and then develop into papules and vesicles and pustules and so forth. But the lesions do progress through this evolution. And of course, whenever you see a patient, they may be at any particular time point on this evolution of their rash. I would say that we've come to see these umbilicated papules and pustules as a somewhat pathognomonic sign of Mpox. Of course, there are a few other things that can do that. But these umbilicated papules, some of which have a necrotic center and which are often very firm and deep-seated, are classic for this infection. The incubation period is 3 to 17 days, and these lesions are typically not asymptomatic. They're often painful or maybe just itchy. Lesions can be asynchronous on different parts of the body, so they may be at different time points in their evolution on different anatomic locations. And most people have fewer than 50 lesions. I believe the median number in unvaccinated people is 10, and occasionally only a single lesion is present. Here are some examples of Mpox lesions. Those on the top panel there are on the face. I want to make a point about the lesions on the bottom panel, and if you look at that center photo, this is a lesion that is on day 28 of illness. And that highlights that these can be long-lasting and take a while to resolve. People can have lesions on the face, and if you look at the upper left-hand photo, those have this kind of very typical papular appearance with a central umbilication. We also have seen a fair number of patients who have oral lesions or even pharyngeal lesions and may predominantly complain of sore throat or of difficulty managing their secretions. Perianal lesions and proctitis are quite common manifestations of Mpox, and you can see here some of these classic appearing lesions in the perianal area, and then also some intraanal lesions. Now, we've seen enough Mpox cases to know that there are also quote-unquote atypical presentations. One, for example, could be a solitary genital lesion, which may be mistaken for a wart or a chancre, depending on its stage of evolution. One of the first patients I saw with Mpox back in 2022, when I think this illness was not on many people's radar, had developed a papule in the genital area and presented to an urgent care where it was frozen because it was thought to be a wart. And then when it ulcerated, the patient returned and was treated presumptively for primary syphilis, but it didn't get better. And then the patient presented again and had testing for Mpox, which was positive. More limited areas of rash may be common among people who develop this infection despite immunization, and we'll talk more about that in a few moments. People have also had Whitlow-like lesions on the finger or on the thumb, And as I mentioned before, some people have presented primarily with sore throat or pharyngitis and occasionally nasal congestion and cough. They may also have other skin lesions, which you could identify on a thorough skin examination. As I highlighted before, people with advanced HIV are at risk for more severe disease with Mpox. And what I'm showing you here is a table from a series of 57 people with severe Mpox in the US. More than 80% of these individuals had HIV, and they often had very severe mucosal involvement, which could preclude them from urinating or having bowel movements, or even from eating. I want to highlight that just under a third of these individuals required ICU level care, so they were quite ill from this infection. And also that STI co-infection was fairly common. People who have severe manifestations of Mpox can have really a range of findings. They may have confluent and necrotic skin lesions that are very long lasting. These are also scenarios where resistance mutations to tecovirimat have been identified. People may develop phimosis and urinary retention or secondary bacterial infections, as is shown in that right-sided photo there. Ocular infection does occur and can be sight-threatening. And then in rare cases, people have developed encephalitis or disseminated infection with shock and death. Now, I mentioned that in this series of people with severe Mpox that more than 80% had HIV. And by and large, these were individuals who had advanced HIV-associated immunosuppression. Around 3/4 had CD4 counts lower than 50. And just a fraction were on antiretroviral therapy, or ART, at the time of their Mpox diagnosis. So who should be tested for Mpox? Well, certainly anyone with a new compatible clinical syndrome, especially if any of these following characteristics are present in the past 21 days. And again, I want to remind you what these lesions typically look like. Almost all people with Mpox do have a rash at some point in their course of the illness, and it may have these various manifestations as we discussed before. So in someone with a compatible clinical syndrome, if they've had close contact with a person who's known or suspected to have Mpox, if they have close contact with a person who has a similar rash, if they're part of a sexual network in which Mpox transmission has been occurring, such as MSM, and then residents in or travel to endemic areas of Africa. And I want to highlight that in the setting of the current Clade 1 outbreak, that if you have a patient whom you suspect has Mpox and who has traveled to Africa in the past 21 days, it's important that you alert the local public health authorities when you perform testing for that patient, so that we can be sure to also test for Clade 1 Mpox, because not all laboratory assays that have been used for this infection will differentiate the infection by clade. I want to highlight the importance of testing for Mpox in people who have compatible clinical findings, even if there are no apparent epidemiologic risk factors. And this is a case of a patient who presented to the hospital during the global Clade 2 Mpox outbreak with bilateral facial lesions that had this fairly typical appearance of an umbilicated papule with a necrotic center. This person did not have any known risk factors for Mpox, but the testing was in fact positive. And after a detailed public health investigation, it was thought that this person may have acquired Mpox from a donut-shaped pillow that they had rested on when receiving a massage. So just a reminder that if you do see someone with a compatible rash or illness, it's important to consider this diagnosis, even if they don't otherwise have factors that might suggest they could be at higher likelihood for this infection. As we'll hear more about later, even if Mpox occurs despite vaccination, the clinical manifestations tend to be milder. So compared to people who've never been fully vaccinated, those who develop the infection despite full vaccination have lower odds of hospitalization and death and systemic illness and fever and headache and malaise. And they tend to have fewer skin lesions. I believe the average number of affected anatomic areas is 1 versus 4 in people who have been unvaccinated. So if you think that a patient may have Mpox, how do you test them for it? Well, acceptable specimen types include dry swabs of crusts or fluid from an open lesion, or dry swabs of intact vesicles or pustules. When I first learned this a few years ago, I was skeptical that simply doing a dry swab of a lesion could have a high sensitivity for diagnosing this infection, but it in fact does. And if you think about it, that's one of the ways that this infection is transmitted, through unopened papules and pustules on the skin. You can also submit scabs from lesions for testing. It's important to obtain samples from different appearing lesions if possible, because people may have more than one skin process at the same time. And very importantly, unroofing vesicles or pustules is unnecessary. We don't need that to establish the diagnosis. And it's also not recommended, because there have been cases of nosocomial transmission to a healthcare worker from a Sharps injury obtained when trying to unroof one of these deep-seated lesions. We're instructed to use a synthetic and not a cotton swab. And the instructions may depend on the local laboratory. And I would always check with your performing laboratory to figure out what they want from you, to make sure that you send them the correct specimen types and that you don't have to call the patient back to retest them. I also want to highlight that in the current setting, where we predominantly have clade 2 Mpox in this country, but there is concern of additional clade 1 cases in people who may have traveled to Central and Eastern Africa, that it's very important that if you do suspect that someone may have clade Mpox, that you alert your local public health authorities, and that you send the specimen to a laboratory which can do clade-specific testing. So for example, in Massachusetts, where I work, we prioritize sending these samples to our state public health laboratory, which can do that additional testing to determine the clade of Mpox. I'm now going to turn things over to my colleague, Dr. Jason Zucker, to talk about Mpox management and prevention.
Good afternoon, everybody, and thank you so much, and thank you, Kevin. That was a fantastic review of when we should be thinking about Mpox, what Mpox looks like, and how to diagnose it. And now we can talk about moving on to managing it once the diagnosis is confirmed or suspected. Next slide, please. When managing a patient with Mpox, the most important thing to remember is that most patients fully recover even without treatment. And as Kevin mentioned earlier, severe outcomes are limited to those who are significantly immunocompromised. With that said, Mpox can still cause considerable morbidity. These lesions are often painful and may become infected. And so supportive care is really essential to help patients manage symptoms during recovery, which, as we just saw, can be prolonged. This includes things like pain management, infection prevention, and monitoring for complications. Next slide, please. So symptom management of Mpox focuses on supportive care. This includes pain relief with things like topical agents like lidocaine gel, oral over-the-counter agents like NSAIDs and Tylenol, as well as prescription medications like gabapentin for things like rectal pain or proctitis, and opioids if needed for more severe pain. By addressing these needs, supportive care can really improve patient comfort and improve recovery outcomes. Next slide, please. While supportive care suffices for most patients, some may require medical countermeasures. Currently, we have several medical countermeasures, including immunoglobulins, antiviral medications, that each have their own specific indications for use. In general, the indications for using medical countermeasures at all include three main categories: patients with severe disease, like those requiring hospitalization or presenting with life-threatening symptoms; those who are at risk of severe disease, like those persons who are immunocompromised; persons with serious underlying skin conditions like eczema or psoriasis; persons who are pregnant; and pediatric persons, as well as for those participating in clinical trials to help us understand the role of these medical countermeasures better. Additionally, for everyone's awareness, the CDC has published an MWR that provides interim clinical treatment guidelines for severe Mpox, offering further directions on management approaches. Next slide, please. The first point I do want to highlight is that given the similarities in the viral life cycle, treatment differences between clade 1 and clade 2 are not necessarily expected. Therefore, when I'm discussing Mpox treatments, I am referring to things that could be used for either clade. Next slide, please. So we'll start by talking about tecovirimat, which was the primary treatment used during the 2022 Mpox outbreak. Tecovirimat was approved via the animal pathway, meaning that we had very limited human data on this medication prior to the outbreak. To gain approval, efficacy was demonstrated through animal studies, and human safety data came from a study involving only 359 healthy individuals. Next slide, please. However, in the United States, tecovirimat was widely used during the outbreak. A recent CDC publication reported that tecovirimat was supplied to almost 7,200 patients, with outcome forms available for only 22%, really limiting our ability to fully interpret the data. Most patients receiving tecovirimat received it due to lesions in sensitive anatomical areas and significant pain. One thing we can take from this data is that tecovirimat was very safe, with few adverse events directly attributed to the drug itself. Next slide, please. With that said, the big outstanding question is, does tecovirimat actually work? The current observational data we have is mixed. Some studies suggest a benefit with a decreased disease progression when started early, or possibly reducing viral shedding, while others showed no shortening of healing time or viral clearance. And so what we really needed are randomized controlled trials to determine whether or not this drug works. Next slide, please. And one of those studies has been completed. The POM-007 trial was conducted in the Democratic Republic of the Congo and studied the effect of tecovirimat on clade 1 Mpox. While the study has not yet been published, the findings were shared at ID Week this past year. Some key points about this trial: it was a randomized controlled trial that involved a 14-day hospitalization. So all participants were hospitalized for the whole 14 days. In order to receive nutritional support and ensure adequate caloric intake for the medication, samples were taken every other day. They were able to do PK analysis. And the primary outcome was whether tecovirimat improved time to lesion resolution, with some important secondary outcomes based on whether or not improved time to lesion resolution based on time to initiation, virologic outcomes, and differences in subgroups like age and severity. Next slide, please. The trial successfully randomized 597 participants with a median age of 15.9. 64% of participants in this study were aged 2 to 18, and just about half were female. The mean time from days to symptom onset were 5.9, with a mean lesion count of about 487, and only 0.7% of participants were living with HIV. Next slide, please. The top line results were released in a press release a few months ago, and they indicated that tecovirimat was safe, but did not improve clade 1 Mpox resolution. And when you look on the right, you can see the Kaplan-Meier curve that shows no significant difference in the time to lesion resolution between the placebo groups in red and the intervention or tecovirimat group in green. Next slide, please. When looking at some of the really relevant subgroups, there was no difference in time to lesion resolution when stratified by treatment onset greater than or less than 7 days. And there was also no difference in virologic outcomes at day 14. Overall, so far from what we know, it's pretty clear that in POM-007, tecovirimat did not show a benefit in treating clade 1 Mpox. Next slide, please. Because there was so much excitement around tecovirimat and we gave out so much of it, there's a lot of curiosity about why tecovirimat maybe didn't work. Is it possible that it's not dosed correctly? Tecovirimat's dosing was initially derived from non-human primate models and validated in healthy individuals. So there's little pharmacokinetic data on persons with Mpox prior to this outbreak. An Italian study on the left investigated the steady-state PK of tecovirimat in 14 hospitalized patients, and they found that actually in patients hospitalized, it was lower than expected. Similarly, early findings from the study of tecovirimat for Mpox done in the United States also noted PK variations among patients with severe Mpox, with PKs that were substantially lower than expected. However, they were still above the MIC 90. It's possible that these variations, though, are still clinically relevant for certain patients and may be really relevant for those with compromised immunity. Next slide, please. However, when they looked at this in the POM-007 study, they actually saw no difference in days to resolution by concentration, suggesting that it's not clear that our dosing is currently what's wrong. Next slide, please. Is it possible that resistance played a role? Well, there's certainly growing evidence of tecovirumab resistance in multiple case reports and observational studies. One notable CDC study, one of the larger case series, looked at the Mpox F13L gene, where single amino acid changes can cause resistance. They identified 96 isolates from 46 patients that were found to have a resistant phenotype. What they all had in common was that they were all severely immunocompromised and had received multiple courses of tecovirimat, leading to a resistant phenotype. At the same time, what's also really interesting is that mutations identified by routine surveillance in patients who did not receive any tecovirimat remained phenotypically sensitive, even with a similar mutation. This really suggests that resistance may have been driven by selective pressure from tecovirimat exposure, and maybe which is more common in immunocompromised patients. Next slide, please. However, what we're seeing now is different. We're now seeing that tecovirimat resistance is not limited to individuals who've received the drug, and recent findings are really suggestive of transmitted resistance. In Southern California, a surveillance network identified 11 Mpox cases with the same tecovirimat resistance-associated mutation. Phenotypic testing confirmed resistance in 10 of those patients, none of whom had prior exposure, and 7 of those cases were able to be epidemiologically linked to a festival, indicating likely person-to-person transmission of this resistant strain of Mpox. Additionally, the CDC recently reported on 18 cases across 5 states with a unique combination of mutations different from those seen in California. Of these 18 cases, phenotypic testing confirmed resistance in 7 of them, none of whom had received tecovirimat previously. This really highlights the potential for tecovirimat to contribute to transmitted resistance, emphasizing really the importance of careful drug stewardship and really understanding its use so we can optimize it and protect it for people who really need it. Next slide, please. So we don't know why tecovirimat didn't work in the DRC study, but what we know for sure is that more data is essential. And so I do want to highlight the NIH-funded STOMP trial led by the ACTG, for which I'm one of the vice chairs. The STOMP trial actually differs from that of POM-007 in that it's primarily clade 2. It's enrolling primarily adults, while the DRC was 60% pediatric. Patients have a different baseline health status, and we're looking at resistance analysis, tecovirimat PK, and trying to understand why this drug may work or in what settings this drug may work. For people interested in referring patients, there are in-person and fully remote options available for enrollment, so participants can enroll from anywhere in the United States. Next slide, please. Given the uncertainty around tecovirimat's effectiveness and the potential for severe Mpox in patients who are immunocompromised, we urgently need more treatment options and to better understand what's available. Next slide, please. Vaccinia immunoglobulin is licensed for treating complications from vaccinia vaccination and is available through the CDC through an expanded access IND. While there's no proven benefit specifically for Mpox, it has shown effectiveness in treating progressive vaccinia, which is another very similar orthopox virus. However, due to its high cost and limited supply, it's generally reserved for severe cases in immunocompromised patients, especially those who would be expected to not mount a strong antibody response. We generally think about using it in those types of patients, and it can also be used for prophylaxis in exposed individuals when vaccination with post-exposure prophylaxis vaccination is contraindicated or not expected to work. Next slide, please. Next up, we'll talk about our other antiviral medications. Trifluridine eye drops are an option for patients with ocular Mpox, though our data is extremely limited. These drops are FDA approved for herpes eye infections and are thought to have activity against orthopox virus as well. The CDC actually recommends considering trifluridine in severe cases of ocular Mpox. Next slide, please. Next is cidofovir and brincidofovir. Cidofovir is FDA approved for CMV retinitis. However, it's rarely been used because of its concern about significant renal toxicity. Brincidofovir, like tecovirimat, was approved through the animal rule, where we have good non-human primate efficacy data, but limited human data only to safety trials. Brincidofovir is also available through an FDA IND. The concern about brincidofovir is there's safety data from trials from other DNA viruses, adenovirus and CMV, where there were relatively high rates of diarrhea, hepatitis, and concerns about other long-term effects like embryo-fetal toxicity, spermatogonia maturation, and depletion and potential mutagenesis. Next slide, please. One of the most interesting things about the in vitro data, though, is that it suggests that combining brincidofovir and tecovirimat results in synergy against orthopox viruses. This synergy, shown in various assays, including in mouse studies, indicates that using both drugs together actually enhances their antiviral effects beyond what either drug achieves alone, and could present an appealing therapeutic option for those individuals with severe Mpox. Next slide, please. The current CDC recommendations for severe Mpox suggest using brincidofovir alongside tecovirimat, given that this animal data is indicating synergy between the two. One thing to note is that, as we mentioned earlier, brincidofovir does often lead to diarrhea, which may impair the absorption of orally administered medications like tecovirimat, and you may need to consider switching to IV in some cases. Additionally, LFTs need to be monitored due to the concern about hepatitis, particularly in people who took it for Mpox very early on in the outbreak. Next slide, please. While systemic cidofovir has rarely been used, topical and intralesional cidofovir has seen broader use with varied outcomes. This is one recent case report that highlighted its potential effectiveness in a gentleman in his 50s with advanced HIV and refractory Mpox. Over 3+ months, he received multiple courses of available treatments with no improvement. They gave him intralesional cidofovir for 3 weeks, which led to the dramatic improvement shown in these images. And that continued despite minimal immune recovery. He actually did not get a recurrence of Mpox in these places. And so it really demonstrates the potential of injectable or intralesional cidofovir, which is not absorbed systemically, so you don't have the renal toxicity issues, and may help for people with significant lesions not improving on other modes of therapy. Next slide, please. So that covers our available treatment options. But I do want to talk a little bit about prevention and vaccination as well. Next slide, please. So one of the things I think is really important to highlight is to highlight what we learned about our community who is most affected by Mpox. This is gay, bisexual, and other men who have sex with men who, after and during COVID, had to face yet another major outbreak. And one thing that's really important is at the start, many adjusted their behaviors to reduce Mpox exposures with decreased number of partners, decreased one-time sexual encounters, decreased sex with partners met on apps, and decreased group sex. And behavior change is never meant to be permanent, but it can serve as a bridge to other things like vaccination, a key protective measure. And some really great modeling work out of the UK suggests that self-protective behavior combined with vaccination is what really played a critical role in controlling the outbreak within affected communities. Next slide, please. Now we'll talk about vaccination. The Mpox vaccine can be used for both post-exposure prophylaxis and pre-exposure prophylaxis. For post-exposure prophylaxis, it should be given as soon as possible after exposure. And animal models suggest that within 4 days it may prevent disease, and 4 to 14 days may reduce symptoms. For pre-exposure prophylaxis, it's recommended for clinical and research lab workers, public health response team members who may not have access to adequate personal protective equipment, and epidemiological risk groups that we'll discuss in just a second. Next slide, please. So I want to talk a second about our data on PEP. We have animal studies that suggest 4 days for prevention and 14 days for reduced symptoms, but we don't have any data in humans. This was an observational study that tried to provide some insight by emulating a sequence of nested target randomized trials, starting each day post-exposure. They conducted a traditional multivariable analysis and a target trial, and among 594 individuals, the adjusted PEP effectiveness was estimated at 78% in the traditional analysis, but dropped to just 19% with an extremely wide confidence interval in the target emulation. And so our data on PEP effectiveness remains limited and inconclusive. Next slide, please. Very different than our data on vaccine effectiveness for prevention. While we may lack randomized controlled trials during this outbreak, I think it's pretty clear from this chart that they would also lack equipoise to do one now. This chart shows that vaccination reduces infection, with one-dose effectiveness ranging from 36 to 86%, and two-dose effectiveness from 66 to 89%. Next slide, please. And vaccination not only reduces infection rates, but also mitigates disease severity. One study that looked at 37 patients with either a prior infection or a complete vaccination course showed that individuals experienced less severe disease with fewer lesions, fewer confluent lesions, diminished mucosal involvement, reduced analgesia requirements, and fewer admissions. Additionally, a study out of California showed a reduction in hospitalization rates following vaccination. And so it's clear that vaccination really provides a level of protection against severe Mpox. Next slide, please. And vaccination impacts not only severity, but also the presentation. Before this started, Kevin and I were talking about how many patients we've seen who had Mpox post-vaccination had much less severe disease. This was a study done at University of Washington, and they looked at discarded rectal swabs and tried to identify Mpox. They found that 1.1% of patients tested had asymptomatic or subclinical Mpox, and that patients who are vaccinated were 4.4 to 11.9 times more likely to have asymptomatic versus symptomatic Mpox than those who are unvaccinated, really highlighting the benefits of vaccination outside of just disease prevention, also reducing severity. Next slide, please. So who should get vaccinated? According to the current ACIP recommendations, a two-dose vaccine series is recommended for individuals at risk. This includes gay, bisexual, and other men who have sex with men, transgender or non-binary people who in the past 6 months have had one of the following: a new diagnosis of an STI, more than one sex partner, sex at a commercial sex venue, sex in association with a large public event, sexual partners of persons with the risk described above, and importantly, persons who anticipate experiencing any of the above. Next slide, please. There are also a couple special circumstances I always like to highlight because these are questions we get frequently. Previous smallpox vaccination may provide some protection, but it may not necessarily be lifelong. And vaccination should be given to eligible persons who were previously vaccinated against smallpox greater than 3 years ago. Pregnancy is not a contraindication to MVA vaccination, and we should keep in mind that persons who are pregnant may have worse outcomes and may have a significant benefit from vaccination if they have sex with or are close contact with people vulnerable to Mpox. Individuals previously infected with Mpox do not require vaccination. Mpox infection actually provides additional immune protection over that of the vaccine. And vaccination is not routinely recommended for healthcare workers, given the effectiveness of routine infection prevention and control practices for this disease. Next slide, please. While we know vaccination has an impact, questions remain about the duration of protection. Early studies indicate the decline in neutralizing antibody titers over time, and previous research has shown that IgG titers against vaccinia virus correlate with neutralization. However, more studies really are needed to link antibody levels with actual vaccine protection against Mpox and track them over a lower period of time. Currently, the CDC does not recommend boosters for any groups of people outside of people who work with high concentrations of virus within a lab. Next slide, please. And this is because we have animal data that suggests sustained vaccine effectiveness. There are non-human primate studies with clade 1 virus that show 2.7 and 3-year effectiveness. And unpublished data of vaccination among healthcare workers suggests protection at least 5 years after the two-dose primary series. Next slide, please. And to me, the thing that's the most compelling is that there's currently no epidemiological evidence of waning immunity. You know, we vaccinated everyone very early on during the same point of the outbreak. And we would expect that if vaccination was waning, we would really see an increase in our epi curve. But it's been remarkably stable at about 56 cases a week for over the past 1 year, really suggesting that our vaccination is holding. And I think something we need to watch closely, because if we were to start seeing an increase of cases, that might suggest that it might be time that we would need boosters in the future. Next slide, please. We also always get the question about, will vaccines work against clade 1 and clade 2 disease? And the Mpox vaccine is actually against vaccinia, not Mpox. So it is thought to be a pan-orthopox virus vaccine, given the similarities between different orthopox viruses. Next slide, please.
Thank you very much. Thank you, Kevin and Jason. That was a wonderful review of epidemiology, move to clinical presentation, testing, treatment, and prevention. So thank you all. Don't forget to put your questions in the chat, and we have time for some Q&A. I see one in here is, and I guess this would be for you, Jason, is Clade 2 virus more resistant to tecovirimat? Any data on that?
Sorry, I coughed and I couldn't turn my
Oh,
camera back on. So I don't think we have a lot of data on that at all, actually. Most of our data on resistance has really been from clade 2 because it's been here in the United States and within Europe. We don't have as much sequencing and resistance data out of the DRC, but I know that groups are working on that, including the POM trial, and we'll know a lot more, but there's no reason to think that it would be, especially when a lot of our resistance is associated with prior use of tecovirimat more than natural resistance of the virus.
That's helpful. Along the lines of clade 1 and clade 2, right now, in terms of requesting clade-specific testing, what would you say, how would you advise folks on that? Just the travel history, or how do you think about that? When to go ahead and request clade-specific testing at this point?
My 2 cents is that, certainly if someone has a concerning travel history, but also otherwise, if you have concerns about clade 1, and this is not an official recommendation, this is what I would do.
Sure.
But, if I have a patient who has Mpox or suspected Mpox, and, their sex partner may have traveled or some other factors that might make me think. And, I think it's probably only a matter of time before there are more clade 1 cases, either from travel or other mechanisms, and we need to be able to detect those when they occur. I don't know, Jason, if you have other thoughts on that. But
No, I think that's exactly right. I think, yeah.
And then it sounds like to do that, working with your state health departments is the best way to go about that currently, correct?
Yeah, I think that's probably the case in many settings. That's certainly what we've been advised to do here in Massachusetts. The most common test that's used to diagnose Mpox really just tells people that it's non-variola orthopox virus, and some additional testing is needed to determine the clade. And so it may not be done, routinely for every patient, unless it's requested.
Excellent. That's helpful. Another question, given the lack of effectiveness of tecovirimat in the POM study, what do you recommend for a severe case? And I think I was thinking about that as you spoke too, conflicting data amongst all the studies as us at practicing clinicians, sort of what would you say when you have a severe case? How would you approach that?
Yeah, I think the way I've been approaching it now, we've limited our use of medical countermeasures more recently to patients with severe disease. And these are the patients who are at highest risk for severely negative outcomes. And so I think, the best we can offer them is a combination of tecovirimat, brincidofovir, and vaccinia immunoglobulin. We really do have a lot more work to do to understand which of these drugs or which combinations of these drugs are the best. But I think for now, the best we can offer patients, because we know their outcomes can be incredibly severe, is a combination of these drugs.
Kevin, would you add to that at all? I know you've seen a lot of these cases clinically.
No, I think that's what I would do as well. Probably also calling Jason.
Yeah. Yes, our network. Excellent. Excellent. Let's see. Stepping back a little bit, sort of big picture, what do either of you think really is the biggest threat to this relative stability? I know that chart you showed with the epidemiology, we really haven't had a huge surge here. And I think some of that is due to the factors that you mentioned. But what do you think the biggest threat is to that relative stability on control in the U.S. as we move forward? We got that report on the news of the first case of clade 1 here in the U.S. so far, so that we have detected.
Now, one thing that pops into my mind is just not continuing our efforts to vaccinate people who might benefit or to give them the second dose if they've only received one. As we know, when we kind of stop vaccinating or reduce vaccination for certain infections, they do increase, and there can be outbreaks. And I think it's important to keep in mind that there are kind of new people who are entering kind of the population of people who may have a higher likelihood of Mpox all the time, people who are growing up and becoming sexually active and things like that. And so I think kind of, keeping our foot on the gas pedal of vaccination is really important to try to maintain the success that we've had in controlling the clade 2 outbreak. I would also just kind of offer that, very early on in the outbreak, a lot of people were seeking the vaccination specifically. There were these really busy kind of mass vaccination clinics and so forth. And now many of the vaccines we're giving are people who are coming into care for another reason. And we identify that they may benefit, and we offer them the vaccine, and they're happy to have it in many cases. And so I think kind of continuing to provide vaccination in multiple different ways is important.
Multiple different settings too,
Yeah.
expanding the number of settings in which we're offering it. How would you advise, primary care physicians or other settings to think about that and have that as part of their anticipatory guidance or screening?
I think ideally it would be included. And, the vaccine is now commercially available. I think it's accessible at some retail pharmacies, which is great, because some people do access vaccination there. I think incorporating it more into primary care and other settings as well. There's also been success with some mobile vaccine clinics at community events and things like that.
Excellent. Besides vaccination, which it sounds like is one of our most effective strategies, and really working on that, what are some other strategies that other communities can think about, to ensure that especially our vulnerable patients are protected?
I think one of the things that, vaccination, I think, is number one by far. But I think the other thing we can do is making sure that both people and healthcare workers remember that this disease is still around. It was summer of 2022, everybody was talking about it and was looking for it. And as cases have decreased, people forget about it. We often see cases that were seen in urgent care and other places where 2 years ago they probably would have made the diagnosis, but now they're not thinking about it. And keeping it at the forefront of people's minds is really important because it allows us to make the diagnosis and allows people to self-isolate and protect from spreading to other people, which is really important because if they don't know they have it, they don't know they need to do anything about it. And so just keeping that out there, especially as cases are so stable, we know it's still around. It's not gone. And so if we don't make these diagnoses, then we're going to give it an opportunity to propagate further.
Yeah, and I think we've seen how effective that is, that those physical controls and self isolation and things like that can really tamp down an epidemic. And then I think also in the ID world, we can see how quickly, you get your slides in early and, and things change in infectious disease. So one, you had brought up that case that, Kevin, you had presented that with somebody with no epidemiologic risk factors, this comes up in infectious disease a lot. Should we rule out TB in this patient or should we rule out Mpox? How do you think about that? And besides taking an excellent travel history and that advice, what do you think about that and testing without those traditional epidemiologic risk factors?
I think certainly if the clinical manifestations are highly suggestive of this infection, I would test, even if none of those epidemiologic risk factors were present. And, if that didn't happen, that would have been missed for that patient, for example.
Yep.
There is always going to be, there will always be cases that fall outside of the, quote unquote risk factors, and we will miss them unless we consider the diagnosis. And so certainly that's unlikely to be the majority of cases. But, as infectious outbreaks continue and mature and change over time, we need to be kind of cognitively willing to consider that and to test if we need to. So, I don't think anyone, not everyone who comes in with a rash needs to be tested for Mpox. But if the clinical manifestations are suggestive, I would certainly consider testing.
Jason, anything to add to that in terms of how you
No, I just think
clinical practice?
I think thinking about the clinical scenario is really important. I think we've all been fooled now before by cases that we thought were syphilis and were Mpox. And I think, especially if you're testing for things like HSV, you're testing for syphilis, those are high on your differential. Mpox needs to be on your differential as well. And so I don't think we need to test it on everybody with a rash, but especially when you're looking at people who might have other or concomitant STIs, we really should be testing for Mpox every time in those scenarios.
Yeah, I think it's the
And,
theme of the title of the webinar, forgotten, but it's not gone. Don't don't forget.
and
So,
one thing just to add, a recent case that was presented, for example, was a patient who came in with proctitis and had initial testing that showed gonorrhea, was treated for gonorrhea, didn't get better. So it's important people can have more than one thing, not to anchor on that one diagnosis. And then additional testing identified that that person had Mpox associated proctitis as well.
yeah, I think that's so important to keep in mind, especially keeping the host in mind. Immunocompromised patients, I think we've learned, can have not always one thing, and so can other patients too. What about globally? Do you think we're doing enough globally at this point? What should, governments be doing to think about this on a global level as a global community, in terms of, protecting our world community?
I mean, I'm not an expert in global health or in government policy, but I mean, from just my view, I think we need more access to vaccines around the world. That is a big thing because we have really good access to vaccination now in the U.S., and that is not the case in many places that are currently experiencing some of the highest numbers of Mpox infections. So that I think is one thing that hopefully the world can solve to help prevent further spread of this infection.
Yeah, I think one of the take homes from the talk was we have this we saw how effective this prevention strategy is. And that's good news and focusing on that. Any last thoughts from either of you? And I'll look for taking one last look at the chat if anyone has any further questions.
Just as we've been reiterating to remember that Mpox is still here, we still need to keep it under differential. We still need to test, and we still need to make every effort we can to get our patients who might be vulnerable vaccinated.
I think that's
And
a great
I will also say, Jason didn't set me up to this, but I would say if you do have a patient who's diagnosed with Mpox, please consider mentioning the STOMP trial to them because we really need to determine, what treatments work so that we can help people going forward.
Yep.
I think that's so important, and a reminder that the slides will be available for everyone who either colleagues who weren't able to join or those who did listen, and all that information is on the slides. So thank you so much, everybody, for joining us today. And thanks again. Have a great day. With all the animation.